Good morning, everybody. I am Dr. Mariana Castells. I work at the Brigham and Women's Hospital at the Hale Building of Transformative Medicine, and I am the director of the Brigham and Women's Mastocytosis Center. And it is my pleasure today to share with you some of our knowledge in mast cell disorders. The first thing that I want to share with you is that there has been a concern since the pandemic about patients with mast cell activation disorders in which we could see potentially an impact on the infection with COVID-19 and the symptoms of mast cell activation, whether the patients infected would have more symptoms of flushing, of itching, of gastrointestinal symptoms that we associate typically to mast cell activation, and potentially anaphylaxis, the most severe of the allergic conditions and disorders. And we published recently that based on our experience and the experience of our European colleagues, that patients who were infected with COVID-19 and had mast cell activation disorders were not impacted by the infection, and they, in fact, did not have mast cell activation symptoms. And this, we went further to investigate why would that be. And the COVID-19 virus has an entry in the human cells through what we call the ACE2 receptor here in your left side. And this receptor is the port of entry that allows the virus to infect humans. And the cells in the nasal mucosa, in the throat, in the lungs, do have high expression of that ACE2 receptor. But in fact, they don't have the mast cells, which are the cells that are inducing mast cell activation, do not have the receptor. So in fact, cannot be infected with COVID-19. And that is the reason why patients with mast cell activation disorders, including mastocytosis and mast cell activation syndromes, do not have severe symptoms of mast cell activation during COVID-19 infection. But when they have here other receptors, when they have viral infections, those symptoms can be more severe. Another concern of us was that COVID-19 vaccines. And we have actually seen that anaphylaxis is a rare event with COVID RNA vaccines, and more females are affected, and nobody has actually died of the hypersensitivity reaction to one of the vaccines. And one of the things that we have been taking is a tryptase level when reactions occur. Whether the components of the vaccine are responsible for those reactions is still in the works, but there is no contraindication for any patient with mast cell activation disorder to be vaccinated. And we actually provided the first two patients with mastocytosis that were vaccinated with RNA vaccines and did very well. Pre-medication is actually something that we recommend for patients with mast cell activation who need to be who are to be vaccinated, but there is no condition based on mast cell activation that would preclude anybody from being vaccinated. And we have here more data on this based on studies from other people. Dr. Jim Aiken, who's in Michigan, also provided evidence that the vaccination with Pfizer, with Moderna, with the Johnson here in your right, was a very safe vaccination for patients with mast cell activation disorders. So I'm going to tell you a little bit about what we call mast cell activation disorders. This is a proposal that was based on the consensus from people in Europe and people in the United States about what do we call mast cell activation. And we have mast cell activation disorders are here listed as primary, MCAS. So those are disorders in which mast cells actually become more frequent. So there is what we call proliferation, and it encompasses mastocytosis, which could be cutaneous and could be systemic, and monoclonal mast cell activation syndrome. We have secondary mast cell activation disorders in which mast cells are more active. They're not more frequent, but they are more active, and that's associated with allergic conditions and other disorders of connective tissue. And then there is what we call idiopathic mast cell activation syndrome, where there is no condition in which the patient could have and induce mast cell activation, but the mast cells are more active, in fact. The mast cell mediators are an important piece of understanding mast cell activation disorders. So we have all heard about histamine, about prostaglandins, about leukotrienes, and about cytokines. And so what we had done is try to relate when patients have more histamine, when patients have more prostaglandin, when patients have more leukotrienes, what happens with the symptoms. And we know that the symptoms of mast cell activation include potentially a decrease in blood pressure. So if there is too much histamine and prostaglandins, there could be hypotension, but there's also a lot of other symptoms. There is flushing, there is hives, there's gastrointestinal symptoms such as abdominal pain, diarrhea, there is bone pain, there is also bone diseases such as osteoporosis, osteopenia. There is also a factor of the central nervous system with a brain fog and a complex, what we call a complex mix syndrome that is induced by an excess of prostaglandins and histamine. So what is difficult in mast cell activation disorders is to be able to understand what mediators are released, number one, and what is the impact of the mediators. And number three, what are the best medications that we can use to treat those patients? And I was mentioning here that we know that histamine induces, the itching, hives, but also gastrointestinal symptoms. We know that patients with mast cell activation might also release heparin, and they release proteases, the more important of those being tryptase. And tryptase has a lot of actions, but we still don't fully understand its biological actions. It has also systemic leukotrienes, which increase the bronchoconstriction in the lungs. So patients with mast cell activation can resemble patients with asthma, where there is chest tightness. We also have prostaglandins that induce also flushing and the brain symptoms. And there is other cytokines and growth factors that could actually induce some other symptoms that we have here. Now, how do we characterize those? So we have here that this is a patient that was published in the New York Times Magazine a while ago. It's a mother. She's 32. She just went to the bathroom, and then her daughter can't find her, and she's unconscious in a bloody pool, and she's feeling hot and dizzy and has a fluttering heart. And she was told by her doctors that it's possible it's a panic attack, and she has a rash that she has had over 10 years. So how come this rash has not been recognized? Because this is a typical rash of what we call cutaneous mastocytosis or urticaria pigmentosa. This patient has been 10 years in the making of this rash until she had this severe event. We have another patient here who's a runner of the Boston Marathon, and he finishes the run. He gets 800 milligrams of ibuprofen, starts flushing, has a severe hypotension, and then the paramedics come. He's intubated, and he's found to have a tryptase of over 2,000 when it's evaluated. And what happened is this gentleman had been having flushing, chronic fatigue, depression, anxiety, bone pain, chest pain. He had been ruled out for heart attacks many times. And he had, when we did a bone marrow biopsy, found to have those mast cell aggregates, and his baseline tryptase was 32, which is elevated, and he was positive for what we call the KIT mutation, D816V, and he had systemic mastocytosis. Another example of mast cell activation disorders, this is also a gentleman who is stung by a yellow jacket in his backyard, and he passes out. He needs epinephrine and resuscitation, and he's evaluated for Hymenoptera allergy. He's started by his local allergist on allergy injections, and he has severe reactions also during the buildup of that. And in one of such, he needs epinephrine, and he has a tryptase level, which is found to be 29. So a bone marrow is done, and the gentleman ends up having the typical mast cell aggregates in his bone marrow, and the Hymenoptera had induced those mast cells to degranulate into induced anaphylaxis. And so essentially what we found here is those patients that I presented to you have, in fact, underlying an aggregation of mast cells in their bone marrow. We have here, in contrast, a woman who has seasonal allergies and also goes in to have allergy injections, and she's not feeling well when she gets her allergy injections. She requires epinephrine. Her immunotherapy is discontinued, but she continues to have those episodes. And she goes to the emergency room. She has hypotension, and her tryptase is found to be in the normal range, 8.75, and she is evaluated for the mutation, and she's found to have the peripheral blood mutation. So when we look at her bone marrow, she has what we call spindle-shaped mast cells that stain with CD25, and she has monoclonal mast cell activation syndrome. So this is the difference between this monoclonal mast cell activation disorder or syndrome versus systemic mastocytosis, where the mast cells aggregate here 15 mast cells together, in contrast to mast cells that only are spindle-shaped and stain with CD25. So when we classify what we call the primary and clonal mast cell activation disorders, we have the cutaneous form that I showed you in the lady who was in the mall, and then systemic mastocytosis, where the most common one would be the indolent one, the kind of good kind, and then three kinds of mastocytosis that are the advanced disease with aggressive mastocytosis, mast cell leukemia, and the mastocytosis associated to hematological disorders. Now we have also the systemic mastocytosis associated with a hymenoptera. So any man who has a severe event with hymenoptera is a candidate potentially for having systemic mastocytosis. And the diagnostic criteria for this is those aggregates of mast cell that I was indicating here, 15 or more, the presence of an elevated tryptase above 20, the KID codon mutation at 816, and the presence of spindle-shaped mast cells with CD25, which indicates that mast cells are activated. And we can also find those mast cell aggregates in the gastrointestinal tract. So patients who we are suspicious about systemic mastocytosis can have also biopsies of their intestinal tract instead of having a bone marrow biopsy to evaluate the potential for mast cells. And one interesting thing about it is a lot of patients come to the mastocytosis center and they say, well, I have, lots of mast cells in my gastrointestinal biopsy. And here we have what we consider to be normal. In the duodenum, we can have up to 51 mast cells per high power field, and that would not be abnormal. So again, there is a great variety of mast cells in our intestine, and it really depends on potential exposures, allergies, and that actually is not a criteria for mastocytosis. The mutation that we have here is the most common D816V, but some patients, 10 to 15% of patients who have clonal mast cell disorders do not have that mutation and have other mutations. And the presence of that mutation here can occur in mast cells or can occur in other cells. So you see here that this was published by a Spanish group that made the case that in the bone marrow, the mast cells that have the mutation here, but other cells may have the mutation, is called multilineage mutation, and that would indicate that the mast cells may have a progression to the more severe disease, more advanced disease. Tryptase is your friend. If anybody wants to be diagnosed with a mast cell activation disorder, they have to have that tryptase level, and the tryptase is found to be elevated in people who have just what we call anaphylaxis, so that patients with peanut allergy, food allergies, other allergies, and you see here that the anaphylaxis mast cell tryptase can go as high as the patient that we saw, over 2,000, and in patients with systemic mastocytosis is a little bit lower, and some of the patients have lower levels of tryptase, lower than 20. For cutaneous mastocytosis, we actually have to recognize the skin, and we see here that in the skin of some patients, those are not beauty grains. These are monomorphic, what we call monomorphic maculopapular cutaneous mastocytosis. And in children, it's called polymorphing. So children that have this has cutaneous mastocytosis, or there is a diffuse form of mastocytosis. And there is also what we call a mastocytoma. So any brown lesion in the skin that when we scratch becomes inflamed is called a diarrhea sign and indicates that underneath are mast cells. And you see here that when we scratch that, we produce what we call a wheal and a flare, and that indicates that mast cells have been activated. One important thing about this is when patients have the adult onset mastocytosis, the lesions come as an adult after 18, it most likely associates with indolent systemic mastocytosis. So this is what we put together with our European colleagues also is, what does that mean to have cutaneous lesions? So in an adult, it means that likely the patient will have indolent systemic mastocytosis. But in a child, it is just the cutaneous mastocytosis and likely temporary. How do we know that? One help we have is to do the tryptase, and tryptase is typically less than 20 in all the children with cutaneous mastocytosis, indicating that by puberty they will be able to overcome and will no longer have this mastocytosis. In adults, is more like little dots, monomorphic, and it has a tendency to stay. And the association with anaphylaxis, as I mentioned to you, either by Hymenoptera, by a medication, or by allergy injections, is much higher in the adults than in the children. We have here a child who had, and we published that recently, just before the pandemic, 4-month-old boy who had fever, a viral disease, and his skin blistered, and there was no diagnosis. And in fact, the kid had diffuse cutaneous mastocytosis, and you can see here that again, all the mast cells were aggregated in his skin, and this kid survived. But again, his diagnosis was missed at the beginning. He had this pot orange that, when you scratch, had this diarrhea sign. So when we divide our mast cell activation disorders in the patients who have clonal mast cell activation disorders, include the increased mast cell numbers and non-clonal mast cell numbers, we have a newcomer that's called hereditary alpha-tryptasemia, which is that patients who have extra tryptase genes might actually also manifest with symptoms of mast cell activation, flushing, itching, and in addition to that, they have symptoms that are compatible with Ehlers-Danlos like symptoms, like POTS, like postural orthostatic tachycardia, and dysautonomia. So this is a newcomer to the field of mast cell activation disorders, and we're still in the midst of studying and understanding what it is. Here in the side, I have described to you the criteria and how we make the diagnosis, either through a biopsy of the bone marrow or a biopsy of the gastrointestinal tract. Here in mast cell activation disorders, we have that patients have 2 or more symptoms of mast cell activation. They have some increase in their mediators, and they respond more than 50% to the medications that block mast cell activation, which is antihistamine, which is leukotriene blockers, which is prostaglandin blockers, and in certain instances with other medications such as anti-IgE omalizumab. We have here mast cell activation symptoms in systemic mastocytosis. So patients with systemic mastocytosis can have the typical symptoms of mast cell activation. So it's diarrhea, inability to concentrate, mental fogginess, flushing, and that's associated with elevated tryptase, and we have the typical symptom. We have here that this is a patient with allergies, anaphylaxis, and this patient has flushing, hives, and an elevated tryptase, and also has what we call a dysautonomia and a small fiber neuropathy. So again, this is a patient who is very different than the previous patients that I mentioned to you, where there's an additional set of symptoms that he has hyperlax joints, and he has also a small fiber neuropathy. So hereditary alpha-tryptasemia is the new kid on the block, where we have here in chromosome 16 an extra piece genetic material that duplicates the tryptase gene TPSAB1. And here you have pedigrees, and in some families there is like 1, 2 generations, 1, 2, 3 generations. And again, as you see here, there is hypermobility in those patients. There is arthralgias, there is tilt test that's positive, there is venom allergies, there is flushing and pruritus. So again, a mixture of a classical mast cell activation symptoms and some symptoms of connective tissue disorder. And this is associated also with anaphylaxis. So interestingly, those patients with hereditary alpha-tryptasemia who have more material in the TPSAB1 gene, and we can actually, there is a test that's called gene by gene that we can actually associate and find how many alpha and how many beta genes patients have. And this is done through our clinic, but also through you can have it done through local doctors. We can calculate how many genes for tryptase are there. And in calculating that, we can assess the risk for hereditary tryptasemia, which in fact will be associated with an increase in the potential for anaphylaxis. And here we have severe anaphylaxis. And what happens with the extra material is that what we call tryptase actually becomes aggregated, alpha and beta tryptase become aggregated, and they can deposit in connective tissue places. They can also be placed in the endothelium, and they actually produce a risk for those patients who have symptoms such as I mentioned before, hyperlax joints, also vascular endothelium, so tachycardia and decrease in blood pressure, and also anaphylaxis. And as I was mentioning to you, we are in the midst of understanding what tryptase is all about. And we had thought initially that alpha tryptase doesn't have an activating site. Tryptase is part of enzymes that are called proteases, and it does not have an activating site, but alpha tryptase actually is potentially able to be associated and form what we call heterotetramers in vitro and also in vivo. And patients who have this might be susceptible to all the other events that we are mentioning. We here at the Mastocytosis Center have been collecting, and this is 101, the first 101 patients with hereditary alpha-tryptasemia. And what you can hear is that their tryptases range from higher than 11.5, which is the normal range, to levels up to 30 and 40, which is associated with systemic mastocytosis. But those patients didn't have a bone marrow compatible with systemic mastocytosis, and they have here the most common gene association is 2 alpha and 3 beta, or 3 alpha and 2 beta. But there are patients, those are more common, so 5 tryptase genes. Normally it's 4, 2 from mom and 2 from dad, but the patients with hereditary alpha-tryptasemia or HAT have like 5 genes or 6 genes. And we have seen that in those patients, some of them would have anaphylactic events. And we have here that those patients have either anaphylaxis, gastrointestinal symptoms, cutaneous symptoms, also brain fog, anxiety, pulmonary symptoms, cardiovascular, neurological, but a lot of them have neuromuscular skeletal symptoms. And those patients are treated with antihistamines, are treated with sodium cromolyn mast cell stabilizers. They also require epinephrine for the anaphylactic events. And those patients can also be treated with what we call omalizumab anti-IgE very successfully. We have here another example that I wanted to tell you, a 15-year-old female with hives, dyspnea, fatigue, headaches, and she's very sensitive to odors and smells and motions and smoke. So those are things that we still don't understand why those patients are so sensitive to all those environmental cues. And she has flushing, abdominal pain, and the tryptase is not elevated, but she has very elevated prostaglandins. So again, mast cell activation syndromes are based on finding one of the mast cell mediators that is elevated. And when we did the classification of those symptoms, we have here again that idiopathic mast cell activation syndrome is something that is listed here as the non-clonal mast cell activation syndrome that we initially published in 2011 with Dr. Hamilton. And patients present with abdominal pain, dermatographism, meaning that they flush and the itch and the skin becomes red. They have headaches, poor concentration, diarrhea. They may have also anaphylaxis. And predominantly females, and we still, again, don't understand why. Also, they have also allergy to medications, to foods. They have had endoscopies and evaluations, and they have had quite a bit of time of symptoms before they were diagnosed. And as I was mentioning to you, all those are the mast cell mediators that are induced in those patients, and we are able to measure them. So here you have that we can measure the N-methylhistamine in those patients, and you see here that the patients who have either mastocytosis or mast cell activation syndrome have elevated as compared to control. We have also been able to measure prostaglandins, and they are elevated as opposed to controls. And then we have also been able to measure leukotrienes, and they are elevated as opposed to controls. More recently, what we have actually been able to do, and this is a breakthrough in the field, is that we have been able to demonstrate that the patients with mast cell activation disorders, a proportion of them, and we yet have to define which patients are those, but they are referred to our clinic, have a decreased cerebral blood flow, which can be associated with the symptoms that we were saying about symptoms of anxiety and inability to concentrate and what is described as brain fog, but they also have pain, which now we can associate it with the fact that they have a small fiber neuropathy. So this is the test that we do to measure the cerebral blood flow and also the biopsies to be able to assess the neuropathy, the small fiber neuropathy. And you see here that the controls do not have this decrease in cerebral blood flow. The patients with mast cell activation syndrome and patients with have a tremendous decrease in cerebral blood flow. So again, this is not all the patients. There's a subset of patients who have mast cell activation and who have hereditary alpha-tryptasemia who have those very specific symptoms. And how do we treat that? We are able to treat that with a specific avoidance of the triggers. Patients have triggers that can be from foods to medications to environmental triggers. And we avoid medications such as vancomycin, but we don't avoid aspirin or non-steroidal anti-inflammatory medications because the majority of the patients can tolerate them. We provide the patients with pre-medication for procedures so that to prevent mast cell activation. And we have used aspirin for those brain fog as symptoms. And we also use epinephrine. Those patients need to carry epinephrine. And we use also anti-IgE Xolair for patients who have recurrent anaphylaxis with very high success. And one of the things that I want to mention is that sodium chromoglycate, which is a mast cell stabilizer, has been extremely successful at taking away the symptoms in the skin, the flushing, the itching, the symptoms of the brain fog, the anxiety, the inability to concentrate. And we have actually seen a tremendous improvement here as it goes down, and the gastrointestinal symptoms. So somebody who has mast cell activation disorder or symptoms is indicated to have sodium cromolyn. Whether, and I want to finish here, whether patients who have mast cell activation disorders can actually go to the next generation of treatment is a question that we are at this moment studying. We have now new treatment options for mastocytosis, and we have found that blocking this KIT, which is at the basis of the mast cell activation, but also of the mast cell proliferation and of the mast cell multiplication. And there is a new study that has just been recently published with Dr. Jim Aiken, who was formerly at the Brigham and now is in Michigan with his own mastocytosis center, that avapritinib, which was called Blue 285 and was initially developed for gastric cancer, is able to help patients with mastocytosis, whether the advanced form and also the indolent systemic. And we are in the process of doing this. This is already FDA approved for advanced systemic mastocytosis, and we are actually doing a study on indolent systemic mastocytosis. And you see here that this avapritinib is very highly selective for those mutations. So what do we have to do to understand mast cell activation syndromes and be able to treat them? We first have to understand what we call the phenotypes. Is it a HAT? Do we have a genetic trait? Is it systemic mastocytosis or cutaneous mastocytosis? And we have a mutation, the KIT D816V, or do we have like an idiopathic mast cell activation syndrome where the only evidence that we have is the elevation of either the urinary mediators or the tryptase at times of events. We have also that we have to define those comorbidities, such as the anaphylaxis, the allergies, the POTS-like symptoms, the Ehlers-Danlos type symptoms, the small fiber neuropathy. We have, again, the diagnosis, and we are coming with new biomarkers and new therapies. There is, for example, in the mast cells, a new receptor that's called MRGPRX2, which makes the mast cell activate, but not through this IgE, but through other like general anesthetics and antibiotics such as quinolones. So again, this is all unfolding and we're understanding a little bit more. So this, I'll leave you with our recent publications, and I'll be happy to answer and entertain any questions. Thank you so much for your interest and for listening to this.